السلام عليكم جميعا. الحضور الكرام، السيدات والسادة، على بركة الله إن شاء الله نبتدئ اليوم الثاني من دورة التعليم المستمر برعاية السيد عميد كلية طب الأسنان جامعة بغداد الأستاذ الدكتور رغد عبد الرزاق الهاشمي المحترم، وبإشراف السيد رئيس فرع معالجة وتجميل الأسنان الأستاذ المساعد الدكتور أنس فلاح مهدي المحترم. إن شاء الله راح يكون day 2. We will listen to Professor Assistant Prof Dr. Anas Falah Mahdi, which is the head of the Department of Restorative and Aesthetic Dentistry. He finished his BDS degree in 1998 and master degree in conservative dentistry in 2001. And he got his PhD from Newcastle University in United Kingdom in 2017. He got many papers on different aspects of endodontics. His research interest is pulp dentin, complex physiology and pathophysiology. Dr. Anas, the mic is yours. Please, you can start.
Thank you very much, Dr. Ahmed. To present my lecture in the second day of our continuous education course in the Department of Restorative and Aesthetic Dentistry in College of Dentistry, University of Baghdad. My topic is about the biomarker and Dentine-Pulp complex, the role in diagnosis. I hope it will get your interest, and the contents of my lecture is we will start with definitions of the biomarkers and the overview on the subject. Then we will talk about the developmental and housekeeping biomarkers in the Dentine-Pulp complex in the healthy tooth. Specifically, I will concentrate on the matrix metalloproteinase. Then I'll go through the matrix metalloproteinase in the diseased tooth, starting with dental caries, then the pulp inflammatory condition. Then we'll go through the periapical pathosis. And finally, I will talk about the diagnostic tools available in regarding the pulp periapical conditions, and then the clinical implications, challenge, and then the conclusion of my lecture. First, what is the biomarker, or what we call the biological marker? Simply, in any process of the body, we have different like biological processes. It's either formation or destruction, metabolism or catabolism, or could be inflammation or repair. In all these processes, we have a form or different materials to be synthesized, like proteins, or different material to be destructed. And also we have cofactors. These cofactors helping in either formation of materials or in the destruction of these materials. So some of these materials can be used as an indicative for the synthesis or the destruction process. It can be measured, and the measurement of this material can give a clue of the status of the vital tissue in this stage, which is either healthy or in a problem, in a pathosis. So the biomarker is a category of medical sciences that can be measured accurately and reproducibly to represent normal, pathological, or pharmacological condition. This means that, for example, if we have a pathological condition and there is some of the biomarkers is at a high level. So when we give a medication, we can target the same biomarker to see the effect of this pharmacological condition or the drug to tracking the action of the drug. So it's very interesting topic in the whole medicine, not only in dentistry. So according to the National Institute of Health, biomarkers definitions working group define the biomarker as a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic response to a therapeutic intervention. So it's in other words, it's like something that we detect to identify the status of a tissue or the whole organ. The biomarkers could be considered as a response also that are functional, psychological, biochemical at the cellular level or a molecular interaction, which are widely used in the medical field, as we say, in the diagnosis and the treatment. For example, if you go for checking or you have some pathological condition and you went to the physician, so the physician will ask you to do some investigations like different hormones, for example, or targeting the inflammatory condition. So he asks you to do an investigation for inflammatory mediators, like for coronavirus, the ELISA targeting the IgM or the IgG. So it's inflammatory mediators in the blood that can give the level of the inflammation in your condition when you visit the physician. So this is, we want to have like these biomarkers to identify the pulp status, the progress of the inflammatory condition within the pulp. This is as simply, I mean. So the processes of the body can be like summarized in this simple chart. We have normal physiological processes like tooth morphogenesis during the developmental stage, cellular differentiation, tooth development, tooth eruption, or tooth functioning. This is happening in the normal developmental condition of the body. And also we have pathological processes like pulp inflammation in the tooth, pulp inflammation, periodontal and bone inflammation. And after inflammation, we can have a regeneration or healing, like the pulp regeneration, periodontal and bone reconstruction. In each of these biological processes, we can target specific markers to identify whether the developmental condition is going to be in a normal way, or there may be something different that alter the form of the tooth or affect the cellular differentiation. So in the beginning, we have to know what's the present in the normal condition. Then we can subsequently identify the inflammatory conditions and see what is the difference between the normal and the inflammation. So there is an inflammatory progress of the inflammatory markers during the pathosis, while these markers is subside when the tissue go to the direction of healing. So it's very interesting to tackle this biomarkers. For the dental research, the measurement of biomarkers are included in both in vitro and in vivo studies. There is plenty of research about that. For in vitro studies, the biomarkers could be DNA variation or could be RNA expression or protein expression or metabolite qualification. While in the in vivo clinical researches, we have now the like the whole organ in a living status, so we can target the biological process in both human and animal sample. How we can targeting that? By taking samples from the animal or human. The sample could be the body fluids, or the whole organ like extracted teeth, or part of the organ like grafts, tissue grafting. On other side, we have another direction of how we can measuring the biomarker is by using the morphological imaging technology, like by having a radioactive biomarker which can be given to the subject, and then this biomarker, the radioactive, can be monitored by radiograph to see the different in this different in the illustration of this biomarker at different stage of something, which could be normal or pathological. So it's a very huge subject for research. All these parts can be linked with what? With the clinical signs and symptoms. As a physician, as a dentist, we are always looking for the patients and dealing with the clinical signs and symptoms either during history or during examination. The results that we have in the researches could improve our diagnosis and the treatment plan if we mix between these results and what we have in the patients and clinical signs and symptoms. So it's for improving the diagnosis to have better treatment. So the first part, or the part that I am going to talk about, the biomarkers in the which is work in the normal condition. We call it the housekeeping biomarker. The biomarkers that is work during the development and maintaining the healthy status of the environment of the tooth. So these biomarkers are mainly secreted by the dental cells, which is mainly the odontoblast, and could be by other pulp cells. And the function of this biomarker is either in maintaining the normal condition within the vital pulp tissue. So some of these biomarkers is required for the everyday life of the organ, or some of these biomarkers are secreted to the extracellular matrix, which is toward the dentine, and being stored in the dentine to be part of, for example, the defense mechanism, the inflammatory process, which may happen during the life of the tooth. So the housekeeping is some biomarkers or some proteins or material which is formed by the cellular part of the tooth, which kept inside the pulp to maintain the life of the tooth, or to be released for embedding inside the dentine to be used in the future. We have many proteins or many materials that can be explored to identify different parts of the normal life of the tooth. Some of them are protein present in the cell or secreted to the extracellular matrix or toward the dentine. If we are talking about all these, we will not finish for months. So I am concentrating my lecture toward the matrix metalloproteinase, MP. What are these biomarkers? the matrix metalloproteinase is a family of zinc and calcium dependent proteolytic enzymes. The proteolytic enzymes means that the enzymes responsible for lytic of the protein. So their function is to destruction or what we call remodeling of the protein. And these enzymes are formed by connective tissue cells. In the pulp, the connective tissue, the main connective tissue active cells is the odontoblast, and secreted into the extracellular matrix, which is maybe toward the dentine. So these enzymes are formed mainly by odontoblast and secreted toward the dentine. In dentine, the matrix metalloproteinase is part of the protein, is part of the organic matrix of the protein. As we have information about the dentine, it is composed of organic and inorganic. The inorganic is about 70%, while the organic part is about 30%. The main organic part, which is about 90% of the organic content, is collagen, while only 10% is the non-collagenous protein. Part of this non-collagenous protein is the matrix metalloproteinase. So these enzymes are used for synthesis and remodeling of the organic part of the dentine, in part controlling the mineralization process. We are going to talk about more about what the function and furthermore in this lecture. So the matrix metalloproteinase can be divided into 6 main groups according to their structural homology and their substrate specificity. So we have collagenases. These enzymes are targeting collagen fibers and lysing the collagen fibers. So its main work on the collagen present in the anywhere in the connective tissue. So their types are MMP1, 8, 13, and 18. Other is the gelatinases. These act on the other protein present in the connective tissue, the gelatin, and sometimes it's act as a cofactor in the breakdown of the collagen also. Also, we have the stromal-sins, MMP3, 10, 11, transmembranous and membranous type. Also, we have different MMPs and other MMPs, which is one of the most important in them, in this group, is MMP20. It's called enamel sin. So there are a huge group. This is a big group of matrix metalloproteinase. Let's see what's present in the pulp or what's its function in the dentine or the tooth. So the matrix metalloproteinase going to do various physiological processes in pulp dentine complex. According to the literature, it's act as organization, have a function of organization of the matrix before mineralization. So it's organize the extracellular matrix within the predentine region before mineralization. So when it's work like that, it will control the mineralization. Definitely, it controls the mineralization. And when the mineralization is being controlled by these enzymes, so it's also controlling the dentine formation, the peritubular dentine. They found, Goldberg et al. In 2011 have a study found that the matrix metalloproteinase acts an important role in the peritubular dentine formation. Also, these have an effective role in altering the matrix of the dentine during aging. And we are going to talk about more about this in one of the studies. What's this? Enzymes are mainly neutral in like its activity is less in the neutral pH. The activity of these enzymes is less in the neutral pH, while its activity is increased with acidic pH. For example, Caries protease, or during acid etching of the restorative processes. Its function, the function will be destructive for the dentine matrix. And also, we will discuss that later. So several MMPs have been identified within dental pulp, mineralized human dentine, and saliva. So it's not only present in the tooth, it's also present in the saliva. So this is one of the studies by Localize et al. In 2002. He do an immunohistochemistry to identify the presence of MMP20, and he found that this biomarker is present within the odontoblast, and the odontoblast secreted this within the dentinal tubule. So he concluded that this MMP20 is mainly synthesized by the odontoblast and released within the dentinal fluid to be used during, he suggested that this will be used during the caries progression. What's the function of this in the caries progression, he don't know in this study, but it is a good question for further studies. Also, we have another study by the same main author, Localize et al. In 2007, he found that the MMP8 within human dentine, he took dentine from human teeth and ground this dentine, and he found that the main collagenases present in these human dentine is matrix metalloproteinase 8. Its work on cleaving of type 1 collagen, which is the main collagen type within human dentine. So this MMP is present within dentine, and it's ready for work for cleaving of collagen 1 type. Another study by Boyton et al. In 2005, they identified the metalloproteinase inhibitor or inhibition within a tooth germ that have been incubated. They incubated a tooth germ, and they control the expression or the secretion of MMP2, 9, and 20 within this tooth germ of a mouse. They found that when these matrix metalloproteinase, the 2, 9, and 20, if they are being blocked or using material which is marimestate, it's this material, it cleaved these enzymes. If these enzymes have been inhibited, so the morphogenesis and mineralization of the tooth germ associated with this inhibition will be different. So the inhibition of these enzymes alter the morphogenesis and mineralization of the tooth germ. So their action is very vital in the formation, in the differentiation of the cells, and also in the formation of the mineral part of the tooth and mineralization process of the dentine. So it's have a double action. Another study, which is also an immunohistochemistry study, to localize the matrix metalloproteinase 2 within human dentine. In this study by Boschel et al. In 2008, they found that the matrix metalloproteinase antibody is mainly present within 9 to 200 of the inner dentine parts. It's from the pulp dentine border till between 9 to 200 micrometer, the inner part of the dentine, this one. And also, they found it in the last dentine part, which is about 10 to 9 micrometer near the dentino-enamel junction. So they suggest that the involvement of MMP2 in the organization of the extracellular matrix within predentine region, which is the first part of the dentine and the secreted dentine, and the dentino-enamel junction establishment. This is the MMP2. So we have, if we can remember that, firstly MMP20, MMP2, and MMP8. This is all present in dentine. Also, this is another study by New et al. 2011. They found the presence of MMP2 and MMP9 in the inner part of the dentine mainly. Also, they targeted the tissue inhibitor metalloproteinase. So for these enzymes, we have also an inhibitor product which have been also synthesized by the pulp cells, the odontoblast. These act to inhibit these enzymes from being active during the normal condition of the dentine. So in the normal, there is no remodeling. The remodeling is required during secretion or during the inflammatory process. So in the normal, there is also inhibitor in the tissue that inhibit the remodeling action of the matrix metalloproteinase. So to summarize this, that we have different matrix metalloproteinase in the normal part of the pulp, in the normal condition of the tooth. They are present in the odontoblast and also in the dentine matrix. So they're fossilized, they have been fossilized within the dentine to be used during the inflammatory process. Now we jump to another part, which is during the matrix metalloproteinase in a diseased tooth. What is the main disease in the tooth? It is the dental caries. It's our nightmare. It's our target in the work, the dental caries. So the dental caries is an irreversible disease of calcified tissue of the teeth, characterized by demineralization of the inorganic portion, then destruction of the organic substance of the tooth, which often lead to cavitation. So it's a start by the bacteria releasing acids to etch the surface, and this etched surface become more retentive for the biofilm to stop on it, and then bacteria will start to release enzymes to destruct the organic substance of the tooth. So this caries dentine can be simply divided. So I'm not going through the caries, but I'm just simply simplify what is caries, because the lecture of tomorrow with Dr. Ahmed, we will enjoy this journey with him. So the caries dentine can be simply divided into two layers in relation to the bacterial infection and degradation of the dentine organic matrix. The outer layer, which is where is the infected dentine by cariogenic bacteria, and the organic matrix is entirely denaturated, while the inner layer of the caries has partially demineralized dentine and affected by the process of caries, but is not infected with the bacteria. So this is very simple division of the parts of the carious lesion. So the bacterial invasion of the dentino-enamel junction, when it starts in enamel and then proceed toward the dentino-enamel junction, the initial stage of the dental caries is followed by the enlargement of the gap between enamel and dentine, and the lesion propagates along the dentino-enamel junction within the superficial destruction of the mantle dentine. The mantle dentine is the first layer of dentine being formed during the life. It is beyond the dentino-enamel junction. So the first dentine to be affected by caries is the mantle dentine. So the cavity is formed when the fragments of enamel are no longer supported by the dentine, and the cavity will be formed, and this cavity will be filled with food, debris, and pathed in saliva. Now, if we talk about what is the process of bacteria, literature said that the initial destruction of the dentine matrix occurred by the function of the bacterial collagenases or collagenase enzyme. Bacteria has a collagenase. Enzymes cleaved the collagen, but this enzymes is called proteases. They are not matrix metalloproteinase. They are less powerful than matrix metalloproteinase. So the function of this is the initial destruction of the collagen part of the dentine. Then literatures have found that in vitro research show that the cariogenic bacteria induce surface demineralization, and weak protease activity has been demonstrated. Why this is weak? Because also literature found that the proteases of bacteria and the digestion of the collagen matrix is reduced with an acidic environment. This means that if the bacteria start the carious lesion, it's difficult for the enzymes of the bacteria to go forward the dentine during a high acidic environment, which is created also by the bacteria to demineralize the inorganic matrix. So how could the caries progress if these proteases is unable to cleave the collagen of the dentine? What is the main proteolytic enzymes that is going to cleave the collagen within the dentine? It's for sure, it is the embedded matrix metalloproteinase within the dentine, because literature also found that the MMPs, which is a host material within the dentine, is activated by acidic environment and cause a matrix degradation during a high acidic content environment. This means that the host-derived proteolytic enzymes, which is the matrix metalloproteinase, are implied to play a more substantial role in dentine organic matrix degradation during the caries process. So it's a multifactorial, different factors work in the caries progression, like protocol or procedure to end with a caries lesion within a dentine. It starts by the bacteria and end with the host metalloproteinase or the host proteolytic enzymes. It's very interesting, actually. So to control this, the research, one of the big researchers in this field is Jadrhan. He have a systematic review or a review, narrative review about this subject, and he suggests a new term called dentine degradomics, which refer to the field of research aiming to identify the enzymes and their specific role, substrates, and end products in dentine-pulp complex physiology and pathology. Because it's complex, it is started by bacteria and then go forward by the matrix metalloproteinase, the host matrix metalloproteinase. So it's a big field of research, because in the past, the idea that the bacteria is doing the whole job. The bacteria is responsible for the whole cavity. But during the progressive of research and the discovery of these matrix metalloproteinase enzymes within the dentine, the idea become different. The presence of matrix metalloproteinase 2, 8, and 9 within demineralized carious lesion has been identified, and the gelatinolytic activity of these enzymes were four-time increase at low pH. This may suggest that the host matrix metalloproteinase activated by the bacterial acid may have a crucial role in the progression of the carious lesion. This is a study done by the same person, Jadrhan, in 1998. So it's like a process which is related to each other between the bacteria and the host. Also, several studies also show that the activation of the gelatinolytic and collagenolytic dentine matrix metalloproteinase during acid etching or the use of acid adhesive like self-etched or all-in-one adhesive. This is also a big drawback in the adhesive dentistry, because one of the problems in adhesive restoration is debonding after a period of time. It's called long-time proteolytic degradation of the adhesion between the dentine and the adhesive material. It's a big subject, and it's have many papers how to inhibit the action of these metalloproteinase within the dentine. However, it is not possible to determine with certainty the exact role and importance of matrix metalloproteinase derived either from saliva, dentine, or pulp. Pulp means via dentinal fluid in the progression of the dental caries, because we have these enzymes are present in the pulp, in the saliva, and also in the dentine, and in the dentinal tubules, in the fluid of the dentinal tubules. So which of these is acting during the caries progression process? It's a huge subject of research. So the MMP9 is perhaps the most abundant salivary matrix metalloproteinase and predominant in dental caries lesion. One of the studies found that the matrix metalloproteinase is the most abundant salivary metalloproteinase. Also, there is a high relative presence of the matrix metalloproteinase 8 and 9 in the outer caries layer. Outer layer of the caries, they found it have an abundance of matrix metalloproteinase 8 and 9, which may indicate that saliva could be a source of these enzymes, because the saliva also have matrix metalloproteinase 8 and 9, supporting the strong correlation between salivary MMPs 8 and caries. This is also interesting study about the dentine degrado mix, the potential role of salivary MMP8 in dental caries. This study by Ashwini et al. In 2020, this is very new or current study. This study suggested that the subjects with caries have elevated salivary matrix metalloproteinase 8 compared with no caries lesion subject. So they examined healthy person with no caries and other subjects have caries and measure the level of the matrix metalloproteinase in their saliva. They found that the subjects with the caries have higher level of matrix metalloproteinase 8 in their saliva. And another important finding is that whenever the carious lesion is more in this subject, they have more expression of matrix metalloproteinase in their saliva, suggesting that the salivary matrix metalloproteinase A play an important role in the degradation of dentine and caries progression. Another study by the Tersorial et al. 2010, which is who measured the level of matrix metalloproteinase activity during age. He take different subjects with different ages, and he found that the matrix metalloproteinase level is less in the dentine of the older subjects than the younger one. So this, and also he found that the matrix metalloproteinase is less in the carious tooth of the older subject than the younger one. We have this in our clinical life. We have sometimes caries, which is very fast caries. And on the other hand, we have very slow caries. And this is a good subject for a research. This also could be related to the level of the matrix metalloproteinase present in their dentine, which this study interested in. I'm now going to have another part of my presentation. What do you think? Do you want me to go in it, or we have a break for 10 minutes as you like?
Thank you, Dr. Thank you, Dr. Anas, for your nice presentation for now. Are you happy to receive some questions?
Yes, please, yes.
Yeah. So just to give a break for the audience before we continue to the second part, well, I have some questions for you, if you can have the time to answer it, please. So my first question, when the pH is low, and this happens when we eat frequently, right? So when we eat frequently, the pH of the oral cavity will decrease and become low. And if we have an exposed dentine or a cavitated caries lesion, so we expect that the MMPs will start to work and degrade the dentine. So what's happened when the pH come back to normal? Do the MMPs stop acting in degrading dentine?
Yes, that's a good question. In saliva, we have also a matrix metalloproteinase inhibitor, which is work all the time to buffer what's present in saliva of MMPs. I think this is the switching part of the story. If in some subjects we found, like for example, rampant caries in his oral cavity, this could be that the matrix metalloproteinase in saliva could be, I don't know, I haven't do research about that, but it could be the function of the MMPs, that there is no inhibition for this process. So the matrix metalloproteinase is more active in these subjects than others. So it's a good research path for, it's a good question for researchers. Actually, it's all my question, my lectures today is raising many questions about the subject. So it's the field is open for the researcher actually. So it's always, all the time, there is a buffer in the saliva. This, I think it's the answer for your question.
Yes, it's very clear for me now. My second questions are MMPs are sequestered in the dentine similar to the growth hormone factors. You know, we have bioactive materials or bioactive molecules like growth hormone factors. These are sequestered in dentine. So when we use EDTA, sodium hypochlorite, or biodentine, MTA, we see that there is some research say that these bioactive material will release and will initiate a mineralization process in the dentine, and also it will stimulate the pulp to lay down some mineralized tissue. That's why we see with biodentine and with MTA, we got a better mineralization in case of pulp exposures, for example. And in case of indirect pulp capping, we see a better response of our treatment. And this may be to one cause, which is release of the sequestered material or sequestered bioactive materials in the dentine, which is the growth hormone factor. So my question is, RMPs sequestered in the dentine during the dentinogenesis process, and then when they exposed to acids of bacteria, they will release and will start degradation of the dentine.
Yeah. The matrix metalloproteinase is proteolytic enzymes. The function of these enzymes is remodeling of the dentine matrix. This happened when the collagen fibers is exposed. When this is all the time happened when we have an acid age. So this process activate the matrix metalloproteinase to degrade the dentine organic matrix to like it's a defensive mechanism. It is a defensive mechanism. It's to occlude the dentinal tubules, the open dentinal tubules, by this denaturated dentine matrix, and to have a plug to prevent the connection between the pulp and the outer surface. It's a defensive mechanism. It's a remodeling, but its function with the continuous acidity is continuum. So when the bacteria retain their acidic environment in a field, they continue forming acids. So the demineralization process is continued, and the denaturation of the matrix or the organic matrix is also continued. So this is what happened when in the case of the adhesion, like in the adhesive dentistry, there is also an exposed of the dentinal tubules. So the there is a demineralization of the organic material, inorganic material, and exposing of the collagen matrix. This targeting the matrix metalloproteinase to degrade the exposed dentine, and this will form a gap between the adhesion and the hybrid layer and the dentine, and will lead to debond. Okay. So in case of the bioactive material, I think, I haven't read about that actually, but I think there is part of the remodeling process of the extracellular matrix of the dentine is toward the healing or the repair, not toward the destruction. So this could be the activation of these materials by the bioactive, like mineral trioxide aggregate or the bioactive material, which is used to restore the pulp or the dentine. I hope I answered your question.
Yes, it's very clear. I have a questions from audience. From Dr. Samer, is destructive activity of MPPs, is it the only role of these coenzymes?
They have different roles. They are remodeling enzymes. But during the Caries process, when there is a high acid level, their action will be, the remodeling will continue. It will distract the dentine. But the main function of these matrix metalloproteinase is during the formation of dentine. It's remodeling of the dentine matrix in a way to have like it's a complex process when the organic material of dentine secreted by the odontoblast, it's been thrown to the predentine region. In the predentine, there is the maturation of the collagen fibers is happening in this region. The formation of the fibrils and the connection between these fibrils, the quadrihelix bonding between the collagen is happened in the predentine region. And also the matrix metalloproteinase controlling the other protein, the extracellular matrix protein, rather than the collagen, which is the proteoglycan and glycoproteins, to be covering the collagen surface and receiving the minerals on the surface of the collagen to form a calcified tissue with its uniform shape. So its function actually in the formation, and these enzymes being sequestrated within the dentine because it's a part of the extracellular matrix, the non-collagenous protein part of the dentine. So this is the story.
Okay, thank you very much. I have another question from, I don't know the name, it's Galaxy Note 8. Yeah, are MMPs genetically determined?
Yes, of course. Yes, they are part of the proteins of the body.
Okay, so I have a question from Dr. Lamis. Can you discuss the best way to measure tissue reaction to caries reactions or materials interaction in vitro rather than measuring that in saliva?
The best way for measuring?
Yeah, the best way to measure tissue reaction.
Tissue reaction.
A caries reaction or material interaction in vitro rather than measuring that in saliva.
It's that my main subject today is to function these matrix metalloproteinase, wherever it is, in a tooth or in a saliva or in the blood or in the dentinal tubular fluid, to aid in diagnosis. So I am just throwing knowledge about what is the matrix metalloproteinase and where is it found in the tooth, in the dentine, in the pulp, in the dentinal tubules fluid. So my aim in the lecture is to found with you what could be the way for measuring these matrix metalloproteinase to aid me and you in the diagnosis. So I don't know what's the best way for measurement in vitro. Actually, they have using different methods. They are in different parts of the tooth. If in the pulp, they are doing ELISA test, immunoblotting, and in the dentine also they have used powder of dentine and measuring what's inside of matrix metalloproteinase, and also measuring the activity of it, not only measure the amount, also measuring the level of the activity, what's their gelatinolytic activity in the dentine. There is many research. I have at the end of my lecture the references. You can also find them, and if you are interested, you can go through. Thank you.
Fair enough. Fair enough. I have a question. You mentioned MMP8, so can be which is mostly predominant in saliva, right?
Yeah.
Yeah. So MMP8 can be considered an indicator for caries risk development?
Yeah, could be. Yeah, this is a good question. Yep.
So so you say MMP8 is very high in patients with multiple carious lesion, right?
Yeah.
And this can indicate that MMP8 is usually present in those people, which can indicate their highly risk for caries, right?
Yeah, yeah, of course.
Do you have any reference for this, or
yeah, I've got one which is I've showed you before.
Yeah.
And also this one, which is on the screen.
Yeah.
They found that the level of MMPs, which is one of them, the MMP8 also, is higher in younger than older in the Dentine-Pulp complex. And also, I think it's one in here, this one, the potential role of salivary MMP8 in caries dentine. So it's higher in the patients. The MMP8 is higher in caries than in patient without free of caries. And also the level of MMP8 is become higher when the caries is more in the subject. So whenever you have more caries, you have more MMP8 in the saliva.
Yes, my point was that there is a measuring of caries risk in the patient, and these and this
could
will
be
determine
one of the markers. Yeah, it could be one.
And this will determine your treatment for the patient, because the treatment of highly risk patients for caries is different from patient with low risk. So it could be a test that can be requested instead of following the patient for 3 years to see if he developed a cavity or a caries lesion, to categorize him as a highly risk patient. And you can just order this indicator to see if this person is highly risk person for caries. So I don't know if there is an evidence for this or not, but it's quite interesting. Yeah. Do you have more time? We have a lot of questions for you.
Yeah, as you like. I need maybe 45 minutes or less for the rest of my lecture.
Okay, so we have time. From Dr. Rabi' Jassim, thanks a lot for your nice presentation and very interesting lecture. My question about the most effective method to inhibit the MMPs to get long-standing filling.
Yeah, there is a different research about that. There's different inhibitors used, like surface treatment before using adhesives, like the use of chlorhexidine, ascorbic acid. One of the PhD students that I've examined is Dr. Muhammad Fadel. He's the student of Assistant Prof. Dr. Abdullah Shamma. he have a big study about the using of the magnetic field in tracking and putting a magnetic to increase the absorption of the ascorbic acid within the dentine to improve the bonding of adhesives. It's very interesting study. And also there is different materials that can be used within the adhesive systems to inhibit the matrix metalloproteinase, like using inhibitor for matrix metalloproteinase within the structure, the chemical content of the adhesives.
You have mentioned,
also,
sorry, you have mentioned ascorbic acid, right?
Yep.
So
vitamin C.
So did he use ascorbic acid to fight MMPs?
Yep, yeah, to inhibit the function of the MMPs.
Okay.
And yeah, it's like the improving the ascorbic acid is improving the bond between the collagen, so it's become more resistance to the MMPs.
Okay, so it's not direct inhibition, but it's by complementing this with
their function.
The bond. Yeah, okay, it's very clear. I have one more question. It's similar from Al-Hamza Ad-Dalaimi. Is there any material to stop these harmful effect of MMPs? I think we have answered it. Another question from Dr. Amina Rehan. So can we say that the MMPs is a predictor for caries activity? Yes, I think we did answer that. There is no more question. Please, Dr. Anas, if you can go on with the second part, if you are not tired.
Yeah, I'm good. Thank you very much.
Yeah. Okay. Continue, please.
Thank you.
Yeah.
So now we are going to talk about the inflammatory pulp. This is the process after the caries is going through the tooth and cause inflammation of the pulp tissue. We have always faced this problem, and this is also part of our next lecture tomorrow from Dr. Ahmed. What is the decision to be taken about the pulp? How we can decide that this pulp have reversible or irreversible pulpitis? We always decided that on our history of the pain from the patient, and also by using our clinical investigation that we always do, the vitality test, percussion, the palpation, percussion, and the vitality test. So if the carious lesion has already caused an infection of a large part of the dental pulp, resulting in irreversible pulpitis, or whether a small localized part of the pulp tissue close to the carious lesion has been affected. So in the first scenario, we may try to use the endodontic treatment, and the other scenario for the next one is to do dressing and capping by using a bioactive material. But in each time we did our treatment, we always, for myself, I said always, do I do wrong? If I choose the endodontic treatment, can I maintain the vitality of this pulp? Do I do wrong when I remove this pulp? Because all the time we have difficulty in our endodontic treatment. In our lecture yesterday by Professor Dr. Hussein Al-Hawaizi, he showed us how the complexity of the apical region of the tooth and the presence of the laterally positioned canals. So all these may cause a failure of our endodontic treatment. So if we maintain the vitality of the pulp, it's better, I think. But how we can decide that? what's our decision could be based on. The main decision that can be made, or the exact diagnosis can be made by the histological examination of the pulp tissue. But in this, we have to take all the pulp out. So it's not appropriate for us to take the pulp out and examine what's the pulpal condition to decide our treatment. So there is different published literature about this. Systematic reviews showed that to date, none of the clinical or radiographical investigation that were thought to determine the condition of the exposed vital pulp in teeth with different types of damage could validated by clinical studies. None of our clinical investigation. Also, the dental history, the pain history, vitality test, and the extent of hemorrhage after pulp exposure are the most predictive clinical parameter reported by different studies. We always rely on the pain, or during the vitality test, or when the pulp is exposure, we predict from the hemorrhage extension or the amount of hemorrhage, the presence inflammatory condition of the pulp, or the severity of the inflammatory status of the pulp. But it's just a prediction, we are not sure. So the using of bioactive, or the biomarkers identified from different samples, which could be the dentinal fluid, the pulpal blood, saliva, or gingival crevicular fluid from patients, is another method for the diagnosis that has been thoroughly discussed by authors. So tackling these body fluids, which is either dentinal fluid, blood, saliva, or crevicular fluid, and measuring the amount of the matrix metalloproteinase can provide a useful information about the inflammatory condition of the pulp, as the literature says, and we are going to discuss that now. So this is one of the interesting studies by Zender in 2011. They are taking a sample from the intradentinal fluid by a form of folding polyvinylidene difluoride membrane. This membrane being folded inside the cavity, and they use choosing different subjects with irreversible pulpitis and also healthy tooth with need the replacement of restoration. They have no signs and symptoms. So they have signs of irreversible pulpitis tooth and tooth with healthy status of the pulp. They have just need refilling. They do a cavity. For the healthy subjects, they remove the whole restoration and do proper isolation, putting a rubber dam and removing the seepage of the crevicular fluid, ensure that there is no any fluid act with the cavity, and then they fold this membrane inside the tooth and processing the fluid inside the membrane. For the pulpitis tooth or irreversible pulpitis, they are reaching to the caries before the exposure, leaving the deep-seated caries, and then putting this membrane. Then when they process this membrane, they found a high level of MMP9 within the dentinal fluid. So those form, compares to the clinically healthy teeth, in which their MMP level were sometimes undetectable in this study. So the level of the MMP9 within the intradentinal fluid could be a mark for the inflammation. But if we identify this process, it's clinically difficult, very sensitive. So it's just for research. It's not being developed. Another clinical prospective pilot study is done by Menti et al. 2016. This study using, patients divided into groups. The group 1 is completely asymptomatic teeth with carious pulp exposure. They have an exposure. But the group 2 is the reversible pulpitis with caries exposure also. And group 3-4 is irreversible pulpitis. Group 3 not taken non-steroidal anti-inflammatory, and group 4 is taken steroidal anti-inflammatory. The sample for these two studies are were the blood sample and partial pulpotomy, pulp tissue. So they took two samples. They collect the blood from the exposure site and also did partial pulpotomy and took the pulp tissue. So the total level of MMP9 and tissue inhibitor metalloproteinase 1 were assessed by fluorometric and colorimetric enzyme-linked immunosorbent assay, the ELISA, fluorometric and ELISA. They found that the level of matrix metalloproteinase in asymptomatic tooth, the group 1, were significantly lower than all groups within the pulp samples and within the blood samples. So they found also the level of these, MMP9 is higher in the irreversible pulpitis patient, whether taken or not taken the non-steroidal anti-inflammatory. So this could be a marker or a biomarker for the pulp inflammatory process from the blood of the pulp. This is another biological fluid that we can use for checking the level of inflammation. Another study, which is a recent study by Brozilla et al. In 2020, they also used the folded membrane from the dentinal tubular fluids. Their groups were irreversible pulpitis, reversible pulpitis, and 21 no pulpitis, different groups. But in this study, they used different markers or biomarkers. They used inflammatory mediators, interleukin 1 beta, interleukin 1 alpha, interleukin 6, interleukin 4 and 8, and tumor necrosis factor A, VGF, the vascular growth factor, FGF, the fibroblast growth factor, and the tissue inhibitor, matrix metalloproteinase and matrix metalloproteinase 9. They showed that all these biomarkers were high in the irreversible pulpitis patient in compared to non-pulpitis or reversible pulpitis patient. They used the dentinal tubular fluid in this study. So we have now different fluid that we can found the biomarker in it and judging the inflammatory condition of the pulp. We have the interdentinal fluid, we have blood from the pulp tissue, and also this study is about the gingival cravicular fluid. This study is also 2020, comparing the level of different bioactive or biomarkers. These are neurokinins A, the substance P, and interleukin 8, and also matrix metalloproteinase 8. In the pulp tissue, they have a sample of the pulp and also gingival cravicular fluid, samples of healthy and symptomatic irreversible pulpitis teeth, and they measure it by ELISA. They found that the substance P, interleukin 8, and matrix metalloproteinase 8 levels were higher in the pulp tissue and GCF gingival crevicular fluid of patients with symptomatic irreversible pulpitis than other groups, than the healthy. So it's also the gingival crevicular fluid can be used as a fluid in detection of the level of the inflammation of the pulp tissue also. So we have different fluids. It's very interesting. Now, if the inflammatory process of the pulp is going furthermore, so we have now the formation of apical periodontitis, the apical inflammation of the periodontal ligament, which have a pulp origin. So it's an outcome of endodontic infection and characterized by bone regeneration in response to intracanal bacteria. So in this process, we have an early and late stages. In the early pulpal and periapical response to bacteria or their bioproducts, including influx and recruitment of polymorphonuclear leukocytes. These cells and monocytes and the macrophage, they are the same. These cells is one of the main progenitor cells for the matrix metalloproteinase. Their function is to release metalloproteinase which is the part of the pus process formation. And also, when this condition is subside in chronic status, the proliferation of fibroblasts and the vascular elements, and then the infiltration of the macrophage, leukocytes, and plasma cells are characteristic features. This is in the histological section. So the apical periodontitis, we have two stages. There is symptomatic and also asymptomatic, acute and chronic. And the bone loss occurs as a host defense mechanism against infection. During apical periodontitis, several pro-inflammatory cytokines are produced locally to mediate the immune response. We call it the cytokine storm, which is related to the inflammatory process and cause bone resorption and also root resorption and develop the apical periodontitis. Another factor is the presence of the host-mediated enzymes, including also the matrix metalloproteinase, that's responsible for the extracellular matrix protein degradation, causing root resorption and bone resorption. So it's a story of continuous infection and inflammation. So it's not stop until we extract the tooth. This is what happened actually. So in this process, we can targeting this biomarker to identify the inflammatory condition. Since the matrix metalloproteinase responsible for the extracellular matrix degradation, its role during the periodontal inflammatory process has been well addressed. Actually, the periodontist is so far proceeding us, we are the endodontist, in this field. They have different kits to determine the inflammatory condition of the periodontal health of the patient. And I will go on to talk about them further in this lecture. So they can measure different studies measuring the activity of specific biomarkers, such as also matrix metalloproteinase during periodontal and peri-implant disease. The level of these biomarkers have been noticed to be markedly upregulated in proportion to the severity of the disease. And they have what they call a point of care test. The point of care test is a test that can be done routinely. It's very simple and should be reliable and have specificity for determining the level of MMPs to identify the inflammatory condition of the periodontal tooth, or the periodontium of the tooth. If you are more interested about that, you can see Gold et al. 2020. This is a review written by Dr. Sarhang Gold. He's the dean of the University of Sulaimaniya Dental School. And one of our colleagues also participates. He's a co-author of this review, Dr. Ali Abbas, from Periodontal Department of our college. They have very nice review. I invite you to read it. It's very informative and it's very useful for me in this lecture. Thank you very much for them. So the apical periodontitis is a heterogeneous form and clinical, from a clinical point of view, depending on its association with a clinical symptom, being either symptomatic apical periodontitis or asymptomatic. And this the clinical validity is expected to depend on the dynamic balance between bacterial content or consortia and the host response. This is what we know. If the bacterial level is activated, the apical periodontitis become much more active and symptomatic. This is what the bacterial studies said, as well as the host immune response activation, including interleukins, tumor necrosis factor, and matrix metalloproteinase 8, also reported in symptomatic apical periodontitis. So it can be tackled from different aspects, either through bacterial biomarker or through the host biomarker, inflammatory mediators. One of the studies done by Walgreen et al. In 2002, they identified the level of matrix metalloproteinase in pulpal and periapical inflammation through the root canal exudate during the endodontic treatment. So they have a periapical exudate collected, this exudate from 11 necrotic teeth. They decide the necrosis by radiograph and during the pulp testing also clinically. And during visit, they start the endodontic treatment in the first visit, doing the debridement, instrumentation, irrigation, and they took sample of the periapical exudate from the tooth and then put calcium hydroxide for the next visit. And they repeated that for 3 visits. And measuring by immunofluorescent assay and immunoblotting, Western blot, the level of the MMP8 in the periapical exudate, or the root canal exudate, sorry. They found that the MMP levels, MMP8 levels, is being decreased with the progress of the treatment. In the first visit, the higher level of the MMP level, MMP8, were measured. And in the third visit, after the application of calcium hydroxide, the level of MMP8 has been reduced. So it's an interesting study. Also, another study by Belmer et al. In 2008, they measure the gelatinolytic activity in the gingival crevicular fluid. So they took a sample from the gingival crevicular fluid from teeth with apical lesion and healthy controls. And they found that the level of MMP9 and 2 is significantly higher in GCF from teeth with periapical lesion than the control. And these gelatinases could represent useful biomarkers also, the MMP9 and MMP2. If we remember the classification,
Sorry, Dr. Anas, do you hear me?
Cravicular fluid from
Yeah.
patient with a chronic periodontitis. They have a periodontal problem and asymptomatic apical periodontitis. This is something mixed, the periodontal lesion, which is due to periodontal problem, and the apical periodontitis, which is due to the pulp problem. But in this case, in this study, they used asymptomatic apical periodontitis. We call it silent tooth. This study concluded that the gingival cravicular fluid composition is modified by chronic periodontitis and asymptomatic apical periodontitis, that its composition of the biomarkers is modified, and found that the MMP 8 and 9 show diagnostic potential for chronic periodontitis and apical periodontitis, whereas MMP2 and the RAP5, the tetratic resistance acid phosphatase 5, are useful only for chronic periodontitis. So this can be taken in consideration during the comparison between the chronic periodontal and the chronic apical periodontal condition. So now, after exploring all these inflammatory, normal and inflammatory condition of the pulp, we need to talk about how we can employ this information in this. What is the benefit as an endodontist to know what's the condition of the pulp? So the most available diagnostic tool to determine pulp condition, starting with case history, then clinical examination, including palpation, percussion, and pulp testing, are almost depending on the pain. The pain is a subjective, very subjective parameter. It's depend on the patient status. If the patient is sometimes when he's like being tired of the pain, he have a pain all the night. So very small tapping on the tooth, he just scream. He will not let you do that. So this is not an easy test to do because it's been affected. Sometimes patients have no signs and symptoms. When you tap on the tooth for percussion, for example, he's feeling very mild pain, but actually this is not a reflection, like a precise reflection of the inflammatory condition. We can predict on it. That's true. We use it, but it's not a precise diagnostic tools to identify the periapical status, inflammatory status, I mean. Also, Caries inspection, detection, and removal protocols cannot precisely identify the pulp inflammatory condition. Even the radiographical examination is only helpful to identify the periapical lesion involvement rather than the pulp itself. So we are so far from that. How to determine the inflammatory condition of the pulp is not well developed in the endodontic field. There is an increasing demand for another tool or kit to identify the pulp status by targeting material secreted by the pulp or periapical region during inflammation or healing to be used during diagnosis and the decision for treatment. So it's very important, as there is a significant expression of matrix metalloproteinase. So these biomarkers in the pulp inflammation and pathosis can be used. One of the biomarkers that we can rely on them by taking samples from the patient mouth, like saliva, gingival cravicular fluid, dentinal tubule fluid, and periapical exudate, whatever we are looking for, and we use the matrix metalloproteinase level in determining that. In perio, as we said, they are so far going further than the endodontist. This table being adopted from the review that I'm talking to you about our friend Ali Abbas, and he listed the number of kits available in periodontal diagnostic tools. They have different kits depending either on the microbial test kit, they measuring the bioactive material released by the bacteria to determine the from samples, either blood or GCF or saliva, to determine the progression of the periodontal condition. Also, biochemical kits or tests using different samples, GCF, saliva, and they are measuring the biomarkers released from the host. For example, the matrix metalloproteinase in saliva, and also genetic kits. One of the most recommended recommended by this systematic review, actually, they are the Perio Safe and Implant Safe. This kit is very simple. They are using saliva or GCF and can be used if they are measure the MMP level, MMP8 level in this sample. They can be used even by the patient himself. It's like a pregnancy test, this one. They put the sample of saliva in this hole, and there is a marker, color marking, appear in this hole to give the inflammatory status depending on the level of MMP8. There is a cutoff point for the MMP8 decided by the literature to be determined the condition of the patient. If it is healthy, there is a number of 6.46 below this number, nanogram per ml, the periodontal status is healthy. Between 4.64 and 20, this is a gingivitis state for the MMP8. And if the MMP8 is between 20 to 60, this is a periodontitis or peri-implantitis, would respond favorably for treatment. And if it is above 60, it not respond favorably to the treatment. So it's very, very informative. But in this plastic indicator, there is only color coding. There is no number. If the number will appear in this machine, put the indicator inside the machine, and it will give you the number. So the patient can use it at home to know the progress of the condition. And when he visits you in the clinic, you can exactly know the level of the MMP8 in his saliva or gingival cravicular fluid. It's very impressive, I think. So what's the clinical implication and challenges present in endodontic biomarker tests? So for specific biomarkers, for each stage of the pulp inflammation is not well identified. Which specific marker? So the literature is not yet decided which of these markers can be used to develop a kit like this one, and which type of the sample that can be used also. There should be much more research to decide, or much more reviews to collect these research to decide how to measure the pulp inflammatory condition. Another challenge is the identification of the pulp condition could be similar to those identified by perio status. Like, for example, there is a measurement between the periodontal condition and the pulp condition, because in both we have high level of MMP8. So we can use different biomarker or multiple biomarker to solve this conflict. So we use like MMP8 and 9, or MMP8 and interleukins, or MMP8 and another inflammatory mediator to identify, is this a chronic periodontitis or gingival problem, or this is a pulpal problem. Another challenge is the procedure for sample isolation, and processing is also complex. If the sample is, for example, saliva and gingival cravicular fluid, is easier to take in than if it is interdentinal fluid. Using for such biomarker, detecting in clinical practice may face different problem also, considering the time and cost limitation of the clinical work, in addition to the acceptance of dentists for the importance of such method in a routine diagnosis procedure. The wellness of the dentist. Actually, we have questionnaire has been done by Dr. Ahmed, and I am a co-author in this one, asking the dentist, it's still in the processing, it's not been published yet, but we have a preliminary data about the which type of diagnostic procedure used by the dentist in his routine work. And we found in our preliminary data that most of the patients that entering our questionnaire is not actually concentrating on the pulp testing, for example, in their routine work. How we can convince these dentists to use another method for detection of the pulp inflammation if they are not using what we know it as in our alphabetical diagnosis for the pulp condition. So this is also a challenge. So we have different challenge that we have to face. Then, as a summary of what we have talking about in our journey today, the use of biomarker in the diagnosis procedure of the pulp in combination with other available diagnostic tools could help to provide better decision and for making accurate treatment. And also tackling this field in the postgraduate study of our department, opening a new era of research. What do you think of that? This will be our the discussion part in our fourth day of this course. So I will gonna talk to you that how we can improve the research in this field in our department. So prepare yourself for that. And thank you very much. This is the references for my lecture of today. It's very interesting reference. I acknowledge all of them for their efforts and work, and hope you have been advantage of this review that I've been done about this subject. And thank you very much for your attention and your patience of our lecture today. If there is any question, I'm ready.
Thank you, Dr. Anas, for your indeed nice presentation and very informative talk in your journey today and our journey in the biomarkers field. My question for you, in the studies of Zender and Menti in 2016, they use MMP9. Why you think they focus on MMP9 in diagnostic pulpal condition?
The MMP9 is one of the marker or one of the MMPs, which is active in the inflammatory condition of the pulp. It's it's similar to MMP8.
Okay, so is MMP9 exclusive to pulpitis?
Yeah, it could be one of the measurements during pulpitis. I can't decide which one is exclusively, because this I'm just exploring the researches, but I can judge that it is one of the biomarkers that can be used, MMP9 and MMP8 and MMP2 also.
Yeah, that's very well clear. My points in these studies in Zender and Menti, I did not see any histologic study. I mean, they just depend on the clinical diagnosis, which is reversible or irreversible pulpitis. And you know, and the audience probably know, that clinical diagnosis is completely not related to histological diagnosis. So if he say that I found this biomarkers in cases diagnosed clinically with irreversible pulpitis, this may not be the real condition in histology. The histology may be is reversible, is not irreversible pulpitis. So I think this is a pitfall in their research. Do you think that?
Yeah, you mean the Menti 2016? It's the
Yeah. Did they use
clinical trial.
Did they use histological examination?
Yeah. They have a sample of blood sample from the pulp.
Yeah. I know they take the. Yeah, I know they take the blood sample, but did they extract the tooth and section the tooth and examine the pulp histologically to determine whether it's reversible or irreversible?
Yeah, they have biopsy of the pulp, like they do partial pulpotomy, and they took this partial this part of the pulp and examine it histology by ELISA.
Yeah, I know that, but I'm talking about their diagnosis. So they did not extract the tooth and section it and confirm their diagnosis that it's reversible or irreversible.
No, they haven't.
Okay, I will talk about this tomorrow. What's the relation between clinical diagnosis and histological diagnosis? So I will talk about this big difference between them and how recent studies cite this problem, and then we will talk about other stuff as well. So my question for you: can we measure biomarkers by a spectrophotometer? Yeah. I probably, so ELISA, can you explain what's ELISA?
Yeah, it's a sample using like tissue sample or fluid. It should be fluid, and they put the if you have an antibody targeting specific antigen in your sample, and this antibody is photo activated. They can absorb light. So they put this antibody, which targeting specific antigen in your sample. If your antigen is already present, this antibody will link with it, and they photo-initiated this solution, and the reflected light will be measured to quantitatively determine the amount of this antigen in your sample. It's like simply like that.
So it's a spectrophotometer basis.
Fluorometric. It's not a fluorometric. It's spectrophotometric. Yeah.
Spectrophotometric. Okay. So then in the near future, we expect to see a handheld device that can measure the biomarkers for inflammatory conditions.
Yeah. There's other methods which I've been talking about in the our perio kit, it's much easier. It's using also photometric device, but it's not an ELISA, it's a different one. I don't know exactly what it is, but it's easier than ELISA. Can give results faster. It's within 5 minutes.
Yeah, but the problem with this, that you need to collect something. But if you have an open pulp, exposed pulp, and you want to know its condition, so it's better to use a handheld device, and probably in the future, we don't know, and it can focus some light and absorb and see the absorbance of the reflectance of the light, and it can detect something in the pulp, like biomarkers or others.
This company have a camera, a scanner for detecting the level of caries.
Yes.
Also, they are using the light to detect the progression of periodontal condition and carious lesion.
Wow.
The same company that's making the PerioSafe kit.
Yeah, interesting. That's very interesting. We don't have any questions from the audience, and we thank you again for your nice presentation, and hope to join you in new lectures in the future. And thank you for the audience. I would like to mention that if you wish to have a certificate of this continuing education course, you need to pass the exam and to attend about 50% of the lectures time. And then there will be an exam at the last day. It's a simple exam, and then we will provide you with the certificate of continuous education. Thank you again, Dr. Enes, and for the audience, and have a good night.
Thank you very much. Bye.
Bye.